Colorectal cancer is one of the most common cancers in the United States. The vast majority of people who have colorectal cancer don't have any symptoms, and most of them have no family members with a history of colorectal cancer. However, there's a precursor to colon and rectal cancer, and that is a colon polyp. And when colon polyps are removed at an early stage, that prevents them from turning into colon cancer. It takes many years for a polyp to turn into colon cancer. That's why getting screening and identifying polyps and removing them early prevents them from turning into colon cancer. So if a patient has no history of colorectal cancer in their family and they have no symptoms of weight loss or anemia or blood in their stool or anorectal pain, then it's appropriate to start screening at age 50. The vast majority of colon cancers start and are identified in patients in their 50s and 60s. If a family has a history of colon cancer and the first-degree relatives, so siblings, or parents, or grandparents, the patient would want to have a colonoscopy performed 10 years prior to their family member's diagnosis. So if your grandfather had colon cancer in his 90s, then it would be appropriate to just have a normal screening at age 50. But if your father had colon cancer at age 55, then it would be appropriate to have screening done 10 years earlier at age 45. The most common screening for colon cancer is a colonoscopy, and it's the only screening that allows you to both identify polyps and remove them simultaneously. Once someone has a colonoscopy, if it reveals no polyps, then the next colonoscopy would be in 10 years based on someone who has no high-risk features in their family. So polyps are commonly found, and most polyps can be removed during a colonoscopy. Some patients will need to come back if they have numerous polyps for removal. If polyps become of a larger size, sometimes we'll need a specialist or a surgeon to remove part of the colon when a polyp becomes very large. The follow-up after a polyp usually involves coming back to the office to discuss the pathology report and discussing when that patient would need their next colonoscopy. That would be based on both their family history as well as the size and the number of polyps they had. So once a polyp is removed, you've completely removed the risk of that polyp turning into cancer, and so there is no risk of that polyp turning into cancer in the future. There are reasons to shorten the interval between colonoscopies if there are numerous polyps or based on the type of polyp, but as long as polyps are removed before they turn into cancer, then a patient should have no change in their life expectancy. And early cancers, when they are removed either with a colonoscopy or if they are removed with surgery, a patient's life expectancy should not change if it is removed at an early stage. A polyp does not mean you have cancer. There are several different types of polyps. Polyp is a precursor to cancer, and left alone, polyps will turn into cancer based on our evidence. So once we've identified someone who has colon cancer, then we order a few tests before intervening to determine any staging. Staging tells us if the cancer has gone anywhere else other than the colon, if it has spread. That usually involves a couple of blood tests as well as CT scans of the chest, abdomen, and pelvis. Once that's been performed, we can determine at a certain level if there's been any spread, and if there's any findings that may require biopsies to determine if there's been any spread. If there hasn't been any spread of the cancer based on those studies, then the patient is ready for surgery to remove that cancer, and then we will look at the tissue that's been removed after the surgery to determine if there's any other treatment needed, such as chemotherapy.